German connection. Doesn't work. Gregor, can you whistle? I wish. So, dear friends and colleagues, thank you for being here. My name is Giovanna Campello. I'm the officer in charge of the Prevention, Treatment, and Rehabilitation section here at the United Nations Office on Drugs and Crime. And it's my great honor today to be here to chair for you a panel of really distinguished speakers, some of them old friends, some of them new friends, that will be talking to us a little bit about some innovation that are happening in the field of prevention. And what better way to start your digestion, right, than to think about it together. So my idea, I often have these ideas that don't quite work, but would be to keep all our speakers around 10-12 minutes so that at the end we have 10-12 minutes for question and answers. It might not happen. So keep your questions in mind in case, because anyway, our colleagues will be here around for the rest of these few days, so you could, in case, catch them later. But let's not make me waste your time and take it off our panelists, and let me introduce our first speaker. Who is Dr. Federica Vigna-Taglianti. And she's Associate Professor of Public Health and Epidemiology at the University of Torino. And she has been doing research in the field of drug prevention for many, many years. In particular, she has been intimately involved with the evaluation of Unplugged, a school-based prevention for early adolescents that many of you might know. And if you don't know, well, you're in good luck, because that's where you will know a little bit more about it, and particularly hopefully also about the amazing work that has been done to take this European program and implement it in Nigeria. Federica, the floor is yours.
Hello to everybody. I will present you the results of a big trial we made in Nigeria to implement and evaluate the effectiveness of the Unplugged prevention program. In 2015, the European Union funded this a very large project in Nigeria to promote healthy lifestyles in schools, families, and communities. And Unplugged was chosen as a program to implement in the schools. Many institutions were involved and gave a big collaboration for the implementation and the evaluation of the program. The program, I don't know if you know it, Unplugged is a school-based curriculum based on social influence and based on skills. It includes social skills, personal skills, knowledge and normative education. It is made of 12 units implemented in class by the class teachers that are trained in a 3-day course before starting the implementation. It is designed for 12, 14 years old pupils, and it was created and tested the first time in Europe from European practitioners and scientists together during a big project funded by European Union, the EUDAP project. If you want, you can still have a look at it at the website, eudap.net. It was tested in Europe, in 7 European countries, and it was shown to be effective. So we have many publications on the effect of the program in Europe. To evaluate the effectiveness of the program in Nigeria, we organized and conducted a randomized control trial. We started with sample size calculations, and it was established that from calculations that more or less 2,000 pupils were needed to, per arm to have a possibility to get significant results. So the Federal Ministry of Education provided a list of 65 federal schools based all around the country in all the zones, the geopolitical zones of the country, which were available to participate in the study. The evaluation involved the entire territory of Nigeria, which is very different from the south to the north. We extracted from this list a second list of schools to include in the trial. I decided to randomly extract the schools depending in a number which depends on the size of the population of each zone. So at the end, the sample we used for evaluate the program is representative of the entire territory and actually proportionate to the population size of each zone. We obviously organized a baseline survey and a follow-up survey. The baseline survey took part in November-December 2015. 32 schools were randomized, 16 to intervention and 16 to control arm. With around about 4,000 pupils participating, filling the questionnaire. So at the end, we had more or less 4,000 pupils participating at baseline and 4,000 pupils participating at follow-up. We linked the questionnaires with an anonymous code because the questionnaire was absolutely anonymous for the pupils, so they were at their ease in answering the questions. Actually, the matched sample, so the sample made by questionnaires who were present with the same code in baseline and follow-up was a little lower than 4,000. We have lost 700 pupils in this matching. For this reason, I made the analysis of the effect both on the sample of the follow-up, which was bigger, and then on the sample of matched questionnaires. Since the results were really similar, I decided to go to proceed with the matched sample because obviously with matched sample I have the baseline variables and I can take into account confounding factors and also the use at baseline. The prevalence of substance use, as declared by the pupils at baseline, was quite low for cigarettes. Pupils had mean age 15 years old. In some zones a little younger, and in the northern zones little older, but more or less around the age of 15. Cigarettes actually, we know from the surveys previously conducted, is not a very big problem in Nigeria, and also we observed 14% of pupils using cigarettes at baseline. Alcohol is becoming, on the contrary, a big problem in all African countries and also in Nigeria. And we have had quite a high prevalence of pupils drinking alcohol. Cannabis use affected more or less 5% of the sample. Obviously, you can see that we get the prevalences lifetime and recent ones in the last 30 days because these are most important for the evaluation of effectiveness. This is already a slide on the effect, since you can see that this is cigarette smoking. The prevalence is low. But what is interesting, always interesting for me to make you reason, is that if we start here from a prevalence which is around a certain percentage, in adolescents it is normal to go that the prevalence go up. This is one of the reasons for which it's so important to have always a control group in a trial who wants to evaluate the effectiveness of a program. Because what the program can do is to slide down this increase. So if the blue one is the control group, the prevalence of smoking is going up very much. The program is able to slow the increase, and so at the end you can see that it is important that if we have an effect, the two lines are not parallel. And this happens for smoking, both in the regular use and in the daily use. We have similar, but actually bigger effect on alcohol. This is the line, the blue one are control pupils, and the red ones are still intervention pupils. So it is very, the daily use of alcohol is the big effect we had. The reduction of daily use of alcohol is the big effect we had in this trial. This slide is on negative beliefs because we studied also some mediators of effect, which we found. I didn't perform mediation analysis still, but in these slides I show some effect on possible mediators, which are quite different from the European experience. For example, negative beliefs, which were increased. The program was able to increase negative beliefs on the three substances: cigarettes, tobacco, alcohol, and drugs. And so negative beliefs goes up in the intervention, whilst it is also interesting to observe that negative beliefs go down in advances ages during adolescence, because one have contacts with substances and reduces negative thinking about it. We perform a multi-level model with calculating adjusted effects, and we can see that the main effect is on alcohol. We reduce in 20% of pupils using alcohol at least once in the last month, reducing 26% regular use, and almost 40% the daily use. We have a bigger effect on younger pupils, 10-14 years old, and among these younger pupils we had an effect also on cannabis. The effect of on mediators was mainly on negative beliefs, which were improved, good class climate, which was improved, and perceived peer use prevalence that was reduced. So we have had an effect on normative beliefs. So Unplugged reached in Nigeria good results. We can conclude that in Nigeria the trial reached the effects in preventing alcohol and cannabis use, increasing negative beliefs and improving class climate and correcting normative beliefs, especially among younger adolescents. And the trial adds evidence on the effect of skill-based programs. I would have still a couple of things. I try. We have studied also, 3 other things in this trial at the moment, zone differences, risk factors for alcohol use and risk factors for cannabis use, and we are publishing all these results. The differences among political zones are very, very important, and I only point out that the northern zones are more affected by use of all substances, of cigarettes, especially cigarettes, cannabis, and drug use, and there is a coherence of results between this increase of use in cigarettes, alcohol, and cannabis, and knowledge that on the other side are lower in these regions, knowledge on the effects on drugs, tobacco, alcohol, and marijuana, and also positive beliefs. Positive beliefs in the zones where the use is higher, positive beliefs are higher, and also positive attitudes. As regards risk factors, very quickly, we studied correlates of alcohol and correlates of cannabis, and we have seen that to live with just one parent, parental drinking and parental permissiveness, friends who drink and low risk perceptions, such as high positive beliefs, are correlates, so are risk factors for the use. And also for cannabis, this happens, and it is very interesting that high socioeconomic status, as we used as an indicator, is high socioeconomic status is predictive of use. Whilst we know that in all our countries is the contrary, is the opposite. I finished. Sorry, so the results of these trials were, to me, that I'm a researcher, very interesting scientific results that we are publishing, and I found very enthusiastic comments from the editors, and I have to thank all Nigerian friends who make this possible.
Thank you so much, Federica, and I wish I could abuse my power as a chair because there are so many important things that you presented on evidence-based practice that could be a learning lesson for all of us. But you know, time is not on our side, and at least you were able to give us these ideas. And let's turn to another old friend, and I trust that Dr. Zili Sloboda doesn't need any introduction to you. But I will indulge myself in presenting you anyway. She's presently the president of Applied Prevention Science International, and she's been a leading researcher on epidemiology and prevention in both governmental agencies, most notably NIDA, but also academic institutions. And in fact, she's a founder of the Society for Prevention Research. And most recently, she has been coordinating a series of books on advances of prevention science. And she has been supporting efforts to promote evidence-based prevention globally, including with us, thank you, Zili, and working on the international standards for drug use prevention and their dissemination through the universal prevention curriculum. And who else could talk to us about linking prevention and practice and research than Zili? The floor is yours.
Giovanna, I have an hour and a half.
No, you don't. You have 10 minutes.
That helps. That's good you didn't hear that part.
I think it was very nice that Federica did a wonderful job, by the way, a wonderful study, because we were talking about evidence-based prevention, and I think it leads very nicely to my presentation, which is we're stepping backwards and talking about what's happening in prevention science, and the impact of prevention science on practice. And there we go. Oh, I want it to be a bit bigger, sort of the explosion of new concepts. I want to sort of present that and sort of connect it to on-the-ground practice and prevention today. We're at a really fascinating point in time historically in the field of prevention because we have so much that has gone on, and we now have a wonderful knowledge base. We do know how to deliver effective interventions. We have evidence-based interventions that we can integrate into our communities. We're not doing that. But what is the background? So the term science of prevention, when it actually appeared in the literature in 1993, John Coit and a number of other prevention researchers wrote an article about the science of prevention. In 1991 and 2010, we established the US and the European Society for Prevention Research. Standards for science of prevention were created by the US SPR, Society for Prevention Research. We actually sat down and said, okay, what makes prevention science different from psychology or epidemiology or statistics? What is it that makes us different? And so we put this document together. I'm hoping we can update that in the next couple of years, but I think it set a nice foundation. I'll talk a little bit about that. Then the European Quality Standards for Prevention came out, which really did a fantastic job of summarizing the knowledge, skills, and competencies that a prevention practitioner need to have in this day and age when we have evidence-based prevention available to us. Then the international standards came out. We started in 2012, it was published in 2013, it's been updated last year. And that sort of lays out what are the evidence base, what's the evidence base for prevention, and what are the strategies and practices of evidence-based interventions for age groups. And I'll show a brief slide of what we looked at in terms of laying out what those evidence-based approaches were. And then with that experience of developing the international standards, a number of us felt this is the time now to really put together a training program for prevention professionals to understand the basis for evidence-based prevention and to learn more about evidence-based prevention and how they need to be delivered. And so I'm going to talk briefly about defining prevention science. As I said, it's a sort of work in progress. We recognize that it's a multidisciplinary field. We draw from many, many disciplines, informs what the science base is, what the theoretical bases are for effective prevention interventions. We sort of outline what the primary goals are. We really ultimately want to improve public health. The research component, I think for me personally, the biggest movement in the field of prevention science forward has been our statistical methodologists, our research methodologists. It's amazing because until the 1990s, it's difficult. Anybody's done, Federica just laid out a very beautiful research plan. To do this kind of research is very challenging, it's very expensive. And we want to do randomized controlled trials, we want to do the best. How do you analyze that? Those methodologists, and I saw a couple of people nodding in the audience, realized that they really pushed this field forward. That's my personal opinion. So it's really important, and so that's included in the science base. And of course, the ultimate is how do you disseminate? How do you disseminate this information? How do you diffuse it so that our communities, our children, are getting the best of the best? The field involves the study of human development, social ecology, identification of factors and processes that lead to positive and negative behaviors and outcomes. And basically, prevention science is the foundation for health education. And we've been in the United States, we've been talking to our colleagues in the health education field. And I'm at Kent State University College of Public Health, and the Department of Health Education is very interested in what we're learning in prevention science. So I think it's very important that we connect with other people. What's nice about prevention science, it's not just research. We use the word science, but it's not just research, it's a combination of practice and research, and that informs prevention science. Because how to deliver these evidence-based programs effectively is really as important as the program itself. So this is a partnership. Major components of prevention science are epidemiology, intervention development, the processes that one goes through in order to develop the intervention, then to test it out at different stages for efficacy and eventually for effectiveness. And then I mentioned the importance of research methodology. And this is a challenge because in the early days we talked about prevention science, I often talked to practitioner groups. And my history is when I was at the National Institute of Drug Abuse, I would go to practitioner meetings and I would be introduced as presenting the research, and half the people would get out and leave the room. And we were very nervous when we were developing the concept of prevention science because we want to have the practitioners. What's the point without practitioners involved? And I went to a practitioner group and I said, how many in the room would mind being called prevention scientists? And nobody raised a hand. I said, does this mean that you would like to be prevention scientists? And they said, yeah. They really want the science because that gives them legitimacy in their communities. So it's important for all of us, prevention researchers as well as prevention practitioners, to use the science to look at who's affected by the behavior, who's vulnerable. It's really important, obviously. What are the consequences? Because we have to understand, prevention practitioners to understand the consequences to make their case for prevention in their communities. And how do you intervene effectively? This is general. Prevention science is general to all kinds of issues that people want to study, violence. But I'm going to focus today on psychoactive substance use because this is a substance use conference. So I'm an epidemiologist by training, and so when I look at a community, I don't look just at substance users. I look at vulnerable populations. We have to understand even those people who are not using substances are vulnerable. I'm not a baby boomer, but the baby boomer generation in the United States, they were protected because they're older population. If you ever looked at the data from the United States on substance use, the rates for people over 60 years of age were always like very low and very flat. With the baby boomer population, they're retiring, their life changes, they're going through divorces, they're going through deaths of friends and family, and their substance use is going up. So we're not just talking about children, we're really talking about vulnerable populations, people at different transition points in their lives. But also we have people who start, there's some data available on discontinuation of use, particularly on adolescents, and people start using, but they discontinue using. So we want to reinforce that, obviously. You can see at each point of these as a prevention professionally, you might want to intervene differently. You might want to emphasize different things. And then there are people who start using, and you want to prevent them from progressing to abuse or to developing substance use disorders. And then, of course, those are the people who are already involved with substance use. Think about an influenza epidemic in your community. Do you just do treatment? No, you do prevention. And we often don't look at it this way in our communities. And I think before the meeting I was sharing the frustration of, in the United States, we have an opioid epidemic and the funding is going to treatment. That's fine, but there's nothing going to prevention, or very little going to prevention. Because we haven't done a good job in talking to our politicians about, this is like an epidemic. It's not the same thing, but it has parallels, and we really need to be better at doing that and have interventions in place in the community that addresses that whole spectrum of behaviors, from universal prevention to aftercare, after treatment. Now, this is a spectrum was developed at the National Research Council in 1994. And I think this is really important. We don't do just prevention, we don't do just treatment. Every community should have an array of services depending on the needs, and that these services are integrated and comprehensive. And if you go away with just one message from me, that's my big thing these days. We've got to achieve this. We've got to work together. The idea behind ISSUP, okay, I'm not going to get finished, but one of the things when we created ISSUP was that we get treatment and prevention people talking to each other and not fighting. It's really important, and that they'd learn together. I'm not going to go into the classifications. I'm going to actually move forward with, this is important, this nature, and this is the underscoring for a lot of the evidence-based program, is this relationship between nature and environment. And there are a number of ways of looking at this. This is my simple slide. This is something even I can understand. So you have an individual child born into any culture. You come with your genetic makeup. That genetic makeup includes temperament, includes reaction, senses, reaction to light and touch, etc. And how you deal with life and challenges in life have a lot to do with how you were parented, what happens when you go to school for the first time. There are all these micro-level environments that impact how we ultimately deal with life, to put it simplistically. But they also is the macro level, the larger things, the neighborhood. Think of a child who is in a poor neighborhood, and just to go to school in the morning is a challenge. They want to go to school, they want to get there, but there's a challenge. So even the macro environment can affect how we deal with life. And basically, as I said, these are the environmental influences. Basically, we're talking about a socialization process. How many of you are familiar with the term socialization? So you understand what we're talking about. Okay. What I wanted to say is that we're reconceptualizing prevention as being a socialization process. And the prevention professional then is a socialization agent. And I just want to do a couple of things, because socialization agents train other socialization agents, like parents. So we have parenting skills programs to help them be better parents. And to deal with they may have 2 or 3 children with different temperaments who require different kinds of parenting skills. I mean, all of us, I have a brother who, if had different parents, he probably would have had a happier life. But also in the classroom management of children, you want children to bond to school. So having the school environment, a positive environment where they feel comfortable and safe, we can train the school officials as well as the teachers to create that. I won't go on, but I just want to end, of course, with that's why we developed the Universal Prevention Curriculum. And I'm being cut off. It's not moving ahead. Anyway, we developed the Universal Prevention Curriculum basically to help prevention practitioners. Here we go. To give practitioners in the field the knowledge base they need in order to implement evidence-based programs, but also to choose evidence-based programs for their community needs, and to do that kind of a needs assessment, how to access the data. We need to give them the skills to implement with effectiveness, and we need to so we're trying to create a profession. Think about medicine. You have a knowledge base, you have a skill base, you have set levels of competencies, there's integrity, and there are ethics. These are the kinds of things that we're trying to develop for prevention professionals. And I'm sorry, I spoke too long. I conclude.
Thank you, Zili, and sorry to have to hurry you, because I thought it was great to move from Federica's presentation that showed us, evidence-based prevention is possible, to all of the background that was needs to be there to bring us to that place, and that we will need to sustain in the next few years. But it also leads us nicely to our next speaker, who will add another piece of the puzzle. He's also been a leader in promoting evidence-based prevention for many, many years. Dr. Gregor Burkhart is the principal scientific analyst at the Public Health Unit of the European Monitoring Center on Drugs and Drug Addiction, our colleagues at the EMCDDA in Lisbon. In fact, he has been leading the work of EMCDDA in prevention since, I will not say, and he's behind the development of many innovation. And to my mind, two stands to mind. One was the Euro Evaluation Tools Bank, which I've been using a lot, and all of us, and thank you, Gregor, for being behind that, and many other things, but more recently, Exchange, a database of evidence-based programs that he will tell us a little bit more about. Thank you so much. The floor is yours.
Okay, good morning. After all, we are in Austria here, and these three classic arguments against the use of evidence-based interventions programs comes classically from Austria. They even made it into Germany. So there are three classic arguments. They don't work, so let's do what we did before all the time. They come from elsewhere, cannot work here because mostly American, and they are too rigid. We can't work with this kind of standardized stuff. And as to the one, we have therefore set up a registry of evidence-based programs to show that some do work, yes. You find them on our website, and the ratings, however, are different from the ratings of other international registries because we only use ratings of European evaluations. That's why they are mostly lower. And they all target stuff like substance use and since recently also violence and delinquency. You see here one of the screenshots from it. You see what is the evidence rating for each of the interventions. I think there's the good behavior game. Obviously, Unplugged this in. Look for yourself when you have time. The mandatory criteria obviously to be active so that people can actually use it, have one good European evaluation at least of good quality. And then good description of control groups. And now comes some nerdy stuff, which is only interesting for me and for Federica. And you see, for instance, what you see is the good behavior game. It does work in Europe as well. There are at least 2 countries have done really good studies. You see a description of the studies, what is in, whom to contact, and so on. And these are the additional scoring aspects that put the score higher or lower, most about usability and transferability. But there is then one classical challenge, how to make this be implemented in real-life situations. We call this the T2 translational problem. And this is basically also the second criticism from practitioners in Europe. They won't work here. They might have been good evidence, but they won't work in my country. And now this is the second pillar of the information in the exchange, that we asked practitioners to give their assessment of their experiences, of their real-life experiences with the implementations of these programs, and they can fill that in continuously. So if you have implemented one of these in Europe, go on, you can put it straight into it. You don't have to wait until once a year we establish the rating, the evidence rating of them. So the idea is a little bit to show this works. People have used it in many countries in Europe, and give even recommendation how to use it. Because the point is that there are 2 information strings into that registry. One is it's usable. That's, for instance, the case of the Strengthening Families program. It's quite popular in Europe. It's a heavy program, it's expensive, but in the evidence ratings, it has the lowest rating of all the entries we have, because all good European studies showed basically not much additional effect compared to business as usual. So the rationales are to show there's a difference between evidence-based principles, so somebody is based on things that should work, or it actually works. I come later back to that. So interventions, we want to make it easier for decision makers to take a decision. Also, the Strengthening Families program is safe. If you want to spend heavily on a program which is not necessarily working well in Europe, you can still do it. It works. Professionals need to see that these programs can be used, they can be adapted, and how you adapt it. And also business organic myths as we have in Europe so often. Things need to be locally grown and locally adapted, and this is a myth in a way. It is easier sometimes to have a complex, very high technology program and simply adapt it instead of invent the whole thing again without any evaluation. But there is still the last challenge, the T3 problem, to put this into daily routine, and that's the biggest challenge. And they're in a kind, they are right. They are rigid and sometimes of use for the reality of Europe. That's why we are going from this year on to include programs that are not manualized, meaning interventions such as local environmental policies at municipal level. Therefore, we will need to change. In October, we'll discuss how we change the entry criteria, because we need to accept interrupted time series or so. But then comes the structural problem. If you want to do people prevention that is not manualized, people need to know much more than the content of a manual. And there we get to the European reality, because manualized programs are not so important in many European countries. You see, they're very important in Spain, in the Netherlands, in Germany, Lithuania, and so on. But other European countries opt more for the alternative, complementary option. We have made a score of how much they do for vulnerable neighborhoods, local alcohol regulation. Then you see the image changes completely. The Nordic countries suddenly get quite dark. France pops up while Spain almost disappears. And no, get ahead. And so we need, for this purpose, if we want people to do on a local, improvised level, evidence-based stuff, they need much more better training, because in Europe there is not a formalized prevention curriculum. There's one course in Vienna about prevention, a PhD course in Croatia, and an online course in Spain. That's all. There is no formal academic training about prevention. People learn something, social work or psychology in the better case, and then they learn the rest on the spot. And that's why we have in Europe adapted Zili's UPC into the EUPC, about which Pierre is going to talk in a second. So, people ask me, why is the EMCDDA so obsessive with the rigorosity of the studies? Because we have a responsibility. We cannot recommend to member states something that's not safe. The ethical point, iatrogeny. There are some programs developed in some countries in Europe that has been spread out, and they are clearly iatrogenic. We leave the freedom to the national registries with which we cooperate to have their own criteria. They can have a level of promising or a level of intervention that worked only in their own country, and later on, when they improve and have better evaluations, these programs can be fed on into our system. So we want only those that we can prove they have cross-cultural effectiveness. They might come from the States or from Canada, but they work in several European countries. And now a bit the balance. If we have very scientific demands, we will have no entries, because nobody will fulfill that in Europe. We are not particularly good in evaluation. The other thing is, if you put the good old inclusive approach, we are back to the good practice thing. And that's so annoying. I'll come to that later. Not annoying, boring. And we had that. 20 years, we had our EDRA system. Great, and I think the mastermind behind it sits somewhere here, Teresa Salvador. But after 20 years, where we only wanted to people do some kind of evaluation, now we want to look really at, does it really work? And this is, so the classics are mostly not right, but I must give them that. Yes, the manualized programs are a limited option. It's right, because not in everywhere they were the first choice. So how to develop evidence-based programs in countries where this is not an option. Finland has never opted for this kind of choice. They need less staff development. What the Austrians are doing, or the Germans like to do, is to train all kind of teachers in prevention contents. This is extremely cumbersome, extremely resource intensive. Different to train one motivated, enthusiastic teacher in an evidence-based program. And we must recognize some are less effective in Europe. That gives a whole entire other session about why these American flagship programs often don't work in Europe. But you can come to the next EUSPR conference in Ghent in September. But still, they are safer than the usual approach. Europe is hit by another wave of populistic, stupid, outdated prevention methods that are especially in the east of Germany, and which have a potential for harm. So they are nice, they have a usual approach, and they allow to embrace failure. You can, from an intervention program that are well evaluated, you can learn why it does not work and what to change in it. And there was a great example in Brazil, and the government did exactly the wrong decision. Because there was the only evaluation in the entire country of 3 programs, they stopped it because the evaluation didn't show effectiveness, even if it was clear why it wasn't effective. They preferred to continue with a program that had never been evaluated in the country. Now, again, to the good quality concept. You see, good practice, what people still like to stick on, is like Leonardo's flying machines. They were totally based on principles of good practice. They used everything what people knew about evidence, yet they never flew. We need to go to somewhere that actually works. So the good practice concept is in the best of all conditions that it has a plausible logic model. For the rest, it's what the German homeopaths call eternal evidence, which means the kids like it, the parents like it, they recall it, it's accepted, involved. We still hang on this old stuff, also in Europe. And we need to go to something that actually flies, something that does behavioral change in the target groups amongst decision, opinion, and policy makers, changes in cultural practices of professionals, that's why the EUPC is important, and changes in social perceptions of prevention. And this would be an ideal system. Do I have still time? It feels so long. Okay. An ideal system should be like that. You have a central, okay, thanks, now I feel relieved. The funding body, where you have a public registry of interventions of programs. Those programs that are only promising, you give the funding for better evaluations. Those who are effective already, you give funding for large-scale implementation, because that's the German disease. The German disease is develop many, many good prevention programs and never implement them, because no other German lender would accept something that comes from whatever, Berlin or for Bavaria. And on a second pillar, put a prevention-specific training program for professionals like the UPC, the EUPC, and if you're very smart, you do an accreditation system as the Czech Republic. The Czech Republic is the only country in the world that does not let any prevention professional get into contact with their kids unless they have got at least 200 hours of prevention training. And the motto to their population is, to our kids, only the best prevention people. And then you can say, for instance, that the funding goes to NGOs that have some of these accredited professionals. And you can combine it. You can say funding goes to NGOs that have trained professionals and has available some nice programs. And you can also set up a club of implementers and professionals that have gone through these trainings. And in fact, this system is being set up by Spain as we speak. They want to do their whole funding system exactly as this is, based on all the tools by the EMCDDA, and now have finished. Thank you.
Thank you, Gregor, not only for being on time, but for giving us a lot of food for thought, and I found particularly eye-opening the idea of moving the concept of registry from the manualized programs to opening it up to the what I would call policies or strategies or environmental interventions, whichever is the name that you prefer. And I think there will be that will be challenging and very, very interesting, but very, very useful work ahead. I have introduced to you today two old friends, and it is my great pleasure to introduce you to a new one. Professor Silvia Cruz is the chair of the Department of Pharmacobiology at CINVESTAV, which is a Spanish acronym for the Center for Research and Advanced Studies of the National Polytechnic Institute in Mexico. And her main areas of interest is neurobiology of addiction, and she will tell us a little bit more about how she used this fascinating field in the field of prevention. Silvia, the floor is yours. Thank you for being with us.
Thank you. I'm a neuroscientist. I actually work with rodents and things like that, but I have been invited to be part of several prevention programs, and I have been very lucky because of that. I'm going to share with you today a couple of experiences. One is related to the AMBAR Interactive Center. and it needs a very well-organized network to function. The other one has to do with inhalant misuse prevention, which is a problem in Mexico and in Latin America, and it's essentially a network based on goodwill. The first one is a museum located in Tijuana, south of San Diego, very, very close to the United States. It is located it was made for this specific community. It is located in a beautiful building specifically designed for this program, which remains of a brain. And the target audience is children and adolescents from 11 to 15 years of age. It also has a Wandering Museum version, which is an inflatable dome that goes from school to school and reproduces the material that we present in the original museum. It's a collective minds project conducted and coordinated by Marilena Medina Mora from Mexico and her team, but also with a very important part of the civil society. The civil society works very hardly to put this together, and through the National Foundation, UMPR National Foundation. As you can see, a scientific committee review all of the materials, not only from Mexico, but also from the National Institute on Drug Abuse. So we were very happy to have this team working together. The museum has 4 different rooms. The first one has to do with science and health, the second one, the human brain, the third one talks specifically about drugs and the risk, the fourth is for prevention, and the fifth one has to do with approaches for teaching parents and teachers positive parenting skills. In the first one, we have key messages for every room. The first one, for example, is that you can learn how to protect yourself through knowledge. The second one is that our brain is our main learning tool, and it's up to us to take care of it. In the third one, we talk about drugs and the risks, and we try to make sure that students understand that drugs can damage our brain even after stop using them. In the prevention room, the students are taught how to deal with difficult situations, such as having a friend or a family using drugs, and how to address parents or teachers to talk about this. This project has been evaluated since the very beginning, as I said, not only the original materials, but also with focal groups, applying questionnaires prior to being exposed to the museum material and after visiting the museum. And it is now continuously being evaluated. With this kind of questionnaires, with 3 columns, I'm sure you're familiar with them, asking what you know, what you already know, what you expect to learn by visiting the museum, and after the visit, and probably after a week, and with a brief intervention with a treatment program, a very brief intervention, a week later we can ask them, what have you learned? And they write their answers, and everybody reviews them. Is now being analyzed because they have a lot of data right now. The museum is a multimedia experience with 4 different rooms, as I said, each one having a different technical approach with holograms, for example, or 3D laser projections. And during the show, some questions are projected in the screen, and children can answer by choosing different letters. They have different colors in their digivotes so that they can be part of a team and have a winning team after the visit. In another room, in the prevention room, this is the double screen room, as you can see here, a teacher is explaining her students how to deal with difficult situations. They have different double screens, animatic, and in the 4th room, they have an immersive experience in a 360 degrees projection screen. After visiting the museum, they receive a comic like this one. It's called The Corpus. They usually don't realize that it's about the body. Corpus is like cuerpo, body in Spanish. And it's supposed to be something that is happening, an invasion is happening in a far, far away kingdom, which turns out to be your brain, and the bad guys are drugs. They usually love this comic. And so far, the museum has received a lot of students, more than 100,000. Putting together the numbers are for the museum in Tijuana and the Wandering Museum that goes from school to school. They have reached almost 9,000 parents and from almost 500 schools in less than 3 years of operation. And the other example I want to go through very, very briefly is inhalant misuse prevention strategies that is based on something completely different. What I tried to do by choosing these two different examples is that you can do something very well organized with a lot of resources, or you can just try to put together individual efforts and try to work as a team. So I was part of the inhalant working group. It is a very nice name, but we were 4 or 5 researchers that went together and we met at the NIDA International Program meeting, and we decided to share every experience that we had related to inhalants and to work together. And we applied what we learned in our countries. For example, here, there's an NGO called El Caracol, which it can be translated as the snail, because it takes time to get things done. And they distribute these postcards, as you can see, like this one, with very simple messages saying like, ouch, it hurts. And in the back part, they have this message saying, if you have one of these symptoms, you need help. They can give this postcard to an ambulance, and they will be taken to a hospital to receive medical care. Also, we work in supervising the contents of several booklets, flyers, and things like that, organizing our contest, trying to say, well, inhalants are dangerous, and you can die because of them. We have also organized a symposium in Canada, another one in Mexico, aimed to policymakers and researchers. And because of that symposium, we were able to convince one of the industrial, this is not working anymore. Can you help me changing the slides, please? Okay. We convinced the industrials to change the name of this duster, which was called just air, compressed air, and gave no idea of risk, to duster and have a proper labeling to make sure that they are not used for getting high. And finally, I realized that there was a lot of experience in Mexico in treating people with inhalant misuse problems, and that nothing was written. So we decided to interview physicians and medical workers and treatment centers and everything to put together a paper trying to show how to treat inhalant misuse, and the paper is out. So I have been very, very lucky to have good friends working everywhere, and they were ready to share their experience, and I am trying to help to distribute this knowledge everywhere. And that's it, 10 minutes, okay?
Thank you, Silvia. I realized that I'm putting a bit too much stress on my panelists, but it's for a good cause. It's for a good cause. I hope you agree with me. And thank you for your insightful presentation, giving us a different perspective from Latin America. And finally, I have for you another friend and leader in linking research and practice. And Per van der Kreeft has been involved in the development and delivery of evidence-based programs throughout his careers, first with the Sloboda, I'm sure I mispronounced this, Per, and more recently with University College Ghent. And this, for example, includes Lion's Quest, Unplugged, of which we have heard a bit before, and a sports program that Per developed together with UNODC, Live Up. Today, he will be talking about the different kind of development of the prevention workforce that Gregor already alluded to, namely the European adaptation of the universal prevention curriculum. Per, the floor is yours.
Thank you very much, Giovanna, for the invitation. the European Universal Prevention Curriculum is the result of an adaptation process, a 2-year European Union sponsored project has focused on adapting the UPC, the Universal Prevention Curriculum, that we can say that is written by the hand of Zili and of course many colleagues. When we were looking at Europe, with the help of Gregor, by the way, we were looking at Europe and we were asking the question, who would be the target group of what we want with that here? We indeed came up with the word DOP, and Gregor has mentioned it already as a sort of by the way, everybody knows what it means, but inside our group we had quite some discussion on the determination of who do we actually target. And not only policymakers, which is often very easily said, but besides policymakers, the people who make actually the policy, we want the people just before them, the experts that are giving them advice. We also need opinioners, opinion leaders, people in press, around the press, but today also really opinioners in the social web, in the social media world. And decision makers also at the very local, working for the mayor, working for the politician, working for the mayor, those local decision makers, very often coordinator of a big school group, the director of a big important NGO, those are decision makers that we target. Not yet the actual field workers. That would be another target from another angle. First of all, of course, availability of effective programs is important. Then we also need the people who implement those interventions, but the level of training is an absolute influence on the effectivity, on the effectiveness of a program. So, focusing on training with a standardized, following quality standards, standardized curriculum was really something that set the objectives for this group. It's a varied group with a lot of variation. The academics in green, the NGOs in red, the government-related institutes in blue. On the left you have the list of partners. There are some project partners also here. And on the right we have the International Institute, the EMCDDA, the EUSPR, UNODC, ISSUP and APSI, and I think I can put the first name present here on any of these institutes. It's a family gathering, isn't it? On the below this, the small illustration also signifies the very robust, solid balance, very solid balance of researchers and practitioners in the group. We really have a high level researchers, but we also have practitioners with a lot of antennas and a lot of liaisons to all kinds of target groups. And as Zili has depicted for us, science needs practitioners and researchers. The adaptation started with a mapping exercise. And on the left, you see the results of the mapping exercise of, in total, 244 courses, trainings in the European member states. We were basing us on the SPAN, a previous European project, the SPAN exercise of mapping mostly academic trainings, and we added a lot of non-academic trainings. So if we noticed on the left what is only present as alcohol and drug targeting trainings, we thought it was really important to focus indeed on substance use. If we saw that there were only 14% of the trainings in English, so accessible for people talking another language, then we thought it would be an important establishment to have 27 member states have access to one English, the same curriculum. And it has been translated already in 9 partner countries and probably more to go. The adaptation used the universal prevention curriculum, and had Zili been given more time, she would certainly have talked a lot about the content of the universal prevention curriculum. We used it. It is enormous. It is enormously robust. It's enormously essential, but then also really enormous. It's a lot of pages and a lot of training days. Using the EDPQS, European Drug Prevention Quality Standards, which are, among others, describing how should you adapt a prevention strategy, policy, program, intervention. And we followed that method to adapt the original UPC to the European version. That meant, for a big part, downsize it, because if we looked at European reality, there are maybe in many countries, many other countries, there are people who have no basis of prevention. There is very, very little prevention education or training. In Europe, we found out and we heard that people don't need so much. They want access to a lot of information, but they do not have the possibility to follow so much training days. Downsizing did not mean, of course, we teach only a little. We teach condensed knowledge. The adaptation process was more sophisticated than that. Together with Zili, who was also part of the core group, we determined significant themes, this slide and the next slide, not to be changed. And I don't know how far the Russian translation is still working, but I still wonder if, working with Russian people, if prevention is not translated to prophylaxis. So a drug use and drug prevention, drugs as such, how is it translated in the so many European languages that we have? A sound and a rigorous definition of substance use is certainly welcome, I think, in many countries. Science of prevention, influencing factors, there's a fact that you need prevention in different settings. Those are significant themes determined. The chapters are grouped in a first part with general concepts, and then a second part with more practical approaches in different school-based, family-based, workplace-based, environmental prevention and so forth. So the adaptation, what did it actually entangle? Surface adaptations are easy, changing, using other examples, using other data, obviously, but deeper adaptation go to technicals, using other graphics or illustrations, not unimportant, cultural and context adaptation, and of course adding other content. Some examples for context adaptation, social and politically, social organization related, are the concept of community, society. What do we actually mean with community-based? We had to refine that, because in a European context that is not understood in the same way everywhere. Advocacy is something that was really mentioned several times, many times actually, in the need assessment meetings. Nightlife prevention setting, focusing on how to work with media. Those were adaptations to the context that were realized. cultural adaptations relating to norms and values. Here we wanted to be not only bullet number 3, not only delicate and not only diplomatic, but also correct in actually avoiding this differentiation of legal and illegal drugs. For example, more focusing, bullet number 5, on ethical choices, ethical possible discussions, than ethical code of behavior. Their adaptations were documented in much more pages than this small extract, which gives us a source for doing further analysis for an adaptation method. Attached to this adapted EUPC handbook, there are 3 training toolkits developed. In a short training of 5 days, the DOP version as we call it, an academic version, and in an online version. The 5-day DOP, Decision Opinion Policymaker version, has been submitted to focus group in the start of the process and to pilot training trials in the second half of the project. It was Rachele Donini's team from Savona in Italy who made this, who led this exercise, and the similarities we found in between left the original UPC and on the right the European adapted version. The similarity were topics and targets. The differences, not so strange, of course, because the differences in the training are alike the differences in the handbook. The training hours on the left, very much. On the right, 31. There is more advocacy, more nightlife setting, less physiology and pharmacology, less workplace. On the other hand, don't forget, in the original complete UPC, there is, of course, much more detail, and some topics like environmental prevention are absolutely more focused. The dissemination, where EMCDDA was originally one of the 5 institutes working with us. During the process, this very important institute in and out Europe proposed that EMCDDA would take up the dissemination afterwards, which otherwise would have been dispersed over 9 countries, over 11 organizations. And with the EMCDDA came along the REITOX, 27, I think, focal points in Europe. There is a training project called ISSUP. It was originally set up for training to work, how to work with EDPQS, and at the very last minute, it broadened the focus, it opened the focus to training in how to use EDPQS plus EUPC. This means that, in the dissemination, there are now the yellow colors are countries that come along with the REITOX system. So thanks to the EMCDDA dissemination, and Dr. Goosdeel, Alexis Goosdeel, announced this morning already that in September the manual will be formally launched. That means that this is an opening to all these countries. What is ahead of us with the ASSUP project? There will be country prevention systems analyzed. There will be a digital platform and, let's say, training coordination set up. The EMCDDA will coordinate the quality of the training and of use of the dissemination. And the EU-SPR, European Society for Prevention Research, meeting indeed in Ghent next year, is gathering in a workshop all these trainers. Thank you very much.
Thank you, Per. And please, let's take that picture down before too many of these panelists are recognized in the picture.
It was a very nice, happy picture.
It was a very, very nice and happy picture. It was one of the meetings in which I had the honor to contribute to develop the European adaptation to the EUPC. Well, I almost managed. We have 10, 12 minutes before the break for questions, and it's still not much time, so I would like to invite to take a few questions, do one round, and then get our panelists to reply, and off we go. I see Orit, Dimitri, and sorry, I don't know your name, but Orit, you go first.
Okay, thank you. Thank you, everybody. It was fascinating. Silvia, a question for you. The museum, okay? I wonder, because you focused on a short-term intervention. Are we still talking about short-term intervention? And did the kids also change their behavior and not only their attitude? And the last question with this is, where are the parents as far as the kids are concerned? Thank you.
We'll take.
Yes, thank you for the very interesting perspectives and covering well the individual and community level interventions, but I wonder what you think about the other side of the problem, which is that the other stakeholders interested in increasing their profit by selling substances, like we can learn from alcohol and now growing cannabis industry. And I think that despite all the efforts of doing more and more individualized level interventions, without proper regulation and taking into account the commercial determinants and commercial interest, all these efforts may not reach the target.
Yes, hi, I'm Rasha from Lebanon. I'm in the Ministry of Public Health in the National Mental Health Program. Thank you all for the insightful presentations. I want to ask Mrs. Federica about the Unplugged, because we are planning to do it in Lebanon with UNICEF in November for a small number of participants in schools. You said in the presentation that the baseline was in 2015, and then the post-test survey in 2016. So I wanted to ask if there is any afterwards evaluation to see the long-term outcome of this program in Nigeria. Thank you.
Thank you very much for this presentation. I appreciate very much the scientific basis of prevention work. But as I have been working for Ministry of Health in Germany for many years, and I know, Georg, you mentioned it, Germany is behind. It could be better, much more better, concerning prevention programs. But I have been working now for many years in Central Asia in an EU program, and with one part of prevention done by our colleagues from Poland, from the National Bureau of Prevention in Warsaw. They do very good work based on the European standards, of course. But what I realize is when we look to what is done, and this is not only in Central Asia, that's what I wish, how to implement these programs, because mostly when you look to what is done is City Against Drugs is mentioned, or there are sports events and banners, drug-free, whatever, city. This is mainly done, although these programs are based on schools and parents in our program as well, but I'm really doubting whether this has any effect, because it's still to bring 20,000 people to a stadium in Ashgabat and saying we are against drugs, and doesn't work. We know this. How can we support or implement these programs, and how to avoid these barriers?
Okay, thank you very much. I am Gusen Nanle Joseph, nurse, a midwife, and social worker. worker in making. I want to ask this question directing to Gregor Burkhart, who presented on evidence-based programs. And particularly, we have observed that people that take substances have been setting like a standard for others in terms of not developing maybe serious illnesses, and they tend to live long. So young people and children tend to say, okay, these people, see how they live long, yet they are living on tobacco for several years. Now, this looks like an evidence, an evidence for them that, oh, I can see this person living for long, yet it seems as if this person is healthy, and it's a basis for me to follow this behavior. So how can we balance, evidence-based practice with this, showing that, maybe to show that there is a better evidence, for young people than just observing these people that are showing wrong examples. Thank you.
Thank you. Good afternoon to all, and thank you for the presentations. Diego Simancas from the Mission of Mexico here in Vienna. Two questions very quickly to Dr. Cruz related to the museum. Firstly, you spoke lengthy about the intervention of the social sector in bringing up the museum and the engagement of school children, kids, and parents. But what about the interactions with law enforcement authorities, with the political authorities, both at local, state, and even federal level? Do they see it as an asset? Are they using it? What's the interaction there? They are bringing actually not only school children, but children under detention, youth under detention. Could it be done? And given the nature of Tijuana and its relationship, very close relationship with San Diego, do you have any binational programs for the museum, so to engage the children on the other side of the border? Thank you.
So thank you all. I think, Gregor, you have the longest list. Maybe you start first, but just before I jump in, we have been able to do evidence-based programming in Central Asia, and unlike what happened in Europe with family-based, we used family-based and we did get results, so at least in that particular context, it did work. But I'm sure that Gregor has things to add.
So I'll begin with Ingo. It's right, because what you say, most countries continue doing nonsensical stuff, which is basically no, it will not work, despite the better evidence. That's why we are focusing from the years to come in our next work programs on the word de-implementation. Not only offering nice stuff, evidence-based stuff, but also engage with policymakers. That's why we need EUPC and other stuff, so that policymakers stop and begin actively fading out things that have no evidence base. I think it's everywhere happening. Because there, in reality, we need to change the paradigm from let things happen to make them happen. We need to be more active in changing professional and particularly policymakers' behavior, because policymakers have the dilemma. They like to have things that they can take political capital out, things that are visible, that are visible to the public, and the public has, as in the German horrible campaign, the public says, finally somebody does something. That's it, the public sees it, and that's very important for policymakers. So we need to find them other ways of evidence-based prevention that gives them also visibility, to invite them to the launch of successful evaluation studies or to other things, to give them a visibility, or to kindergarten programs, or to these kind of stuff. We need to change our behavior. That's why advocacy is so strong in the EUPC. And also in the EUPC, we are strong in the question about environmental prevention that relates to the question from you about the cannabis industries. It has basically tools of how we can steer human behavior, even under a situation where the industries place heavily on automatic processes, on manipulating us, on telling stories about, you know, the intersection between recreational cannabis use and medicinal cannabis. So it's in the EUPC. There are tools for it. The Monitoring Center has launched a quite popular publication about the potentials of environmental prevention. And the third question, yours is very important. That links to the others, because what you say is relevant only for informational approaches. Those that lead people into campaigns where they see how dangerous and how horrible drugs are. And young kids obviously see, and that's pure evidence, because what they see is obviously all these people live. Look at Keith Richards, the guitarist of the Rolling Stones. He's the living example of that all what we are saying and showing how harmful drugs are is not true. So this is why evidence-based prevention is particularly not informational approaches. It's not focusing too much on how horrible drugs are, that they kill you on the long run. It's rather focusing on, as Zili has explaining marvelously, on how you have a healthy, successful, developed life. And that's it. So basically prevention is, as you said, about the socialization. It's about having the skills to get around, to be able to flirt with girls without being drunk, and a problem for Germans and English, isn't it? And all these things. And so you learn, think, how can I control my life and myself and be engaged with others? That's prevention in a way. And the same applies to parents. So it's not about knowing how horrible drugs are. So you're totally right. That's why this information of purely warning, overarching, overestimating, over-exaggerating the dangers of drugs fires back, because people say, obviously, nothing happened.
Well, nothing happens, but, but indeed. I'll give now the floor to Silvia, because at least a couple of the questions were for her.
Yes, thank you. Well, local authorities love the museum, and they say that it's part of their achievements, of course, but they don't give much money. So that's the truth. Now, I would say that teachers and parents are very, very proud of the museum. What about parents? They are always invited to be part of the training program or of the prevention program. But children attend the museum at school hours. So what we need to do is to work with the schools. So they give, they talk about physiology and how to work well in terms of being sober and being good at sports and things like that. Then they go to the museum, and then a treatment center goes to give a brief intervention program, talking about different skills, developing different skills to deal with your peer pressure, everything. And a week later, they can talk about the museum again. So it's a brief intervention, of course. Parents are invited to attend the sessions, and they can do that at schools. So some of the principals decide that they have to go, and some others just invite them.
Thank you. Now to give the floor to Federica. That was a very specific question for you.
Okay. No, in the trial of Nigeria, we didn't follow up. We didn't organize any follow-up. Actually, it was quite difficult to organize this trial. I mean, it was big work. And so you notice that we had quite a big, it's not really dropout, it's not unmatching questionnaires. But these unmatching questionnaires are partly dropout, so, and this dropout was bigger in the intervention schools. So you consider that intervention schools that have to work, control schools have not to work, and we have always a bigger dropout in intervention schools. On the other side, it was the problem, it was of not matching questionnaires, which means that they were not errors in the matching. So one makes a code in the first, in the baseline, and it were different people to participate to baseline and to follow up, which is obvious in a country like Nigeria, or probably in Africa, where pupils goes not to school, and so to organize a follow-up, it was too much, we didn't. Another suggestion, if I would suggest, if you want to organize a follow-up makes sense if you did a booster session in the second year. In Europe, in the EUDAP trial, we organized 2 follow-ups. The first risk is that at follow-ups you have big dropouts. Indeed, and we didn't have booster sessions, and so the effect is maintained, more or less, is maintained in Europe on alcohol at the second follow-up, but in the third one we had 50% dropout, so we couldn't analyze the data. And in any case, now, today, I would organize a follow-up if I would be able to make a booster session.
Thank you very much. I checked with my fellow panelists, and there is no additional points to be made. I invite you all to, check in with them during the break. And before I conclude, and I thank you all, I have a couple of announcements that I've been asked to make. Well, one actually was for me, ISSUP is a big family. We are all here for both prevention and treatment, but prevention is in my heart. And there is another panel on prevention issue on Wednesday at 9 that might be of interest since you're all here. And I've been also asked to announce that there are some training sessions that actually have open slots. And if people are interested, it's very easy to participate. You just turn up and register yourself. The details are in the program, but I'm just telling you which ones are the ones with open slots. Course 11 of the Universal Treatment Curriculum on Motivational Interviewing has open slots. So does course 16 on advanced clinical skills and crisis management. Bear with me. Also, the first course, course 1 of the Children's Substance Use Prevention and Treatment, and the course on schools for coordinators of the Universal Prevention Curriculum has some open slots. So if you're interested, the details are in your programs, and please just turn up and register yourself. With this is the best part. I just would like to thank our panelists. I think we can give them a handful. For giving us a lot of new ideas, and thank you all for your interest and participation, and see you around and enjoy the rest of the conference. Bye.